Howdy, everybody. I hope you are having a great week, that you had a great weekend. We are today going to be talking about a really important subject area in medical sociology, and that is gender health disparities. Now, before we get into that, though, just a reminder about our first paper assignment due Sunday, the March 16th, by the end of the day. Let me just quick pull up that assignment description on the Moodle page, the same description uh, in the syllabus as well. If you scroll to the bottom of the Moodle page, as always, our assignments are listed there. So this first paper that you're writing, you're going to analyze a specific health disparity affecting a particular population group using the social determinants of health as your framework. You're going to explain how various determinants such as socioeconomic status, environment, healthcare access, and social and community context contribute to the health outcome you are analyzing, and then conclude with potential interventions that address these determinants to reduce the disparity. So pick an issue, right? You're going to analyze a health inequity that you choose through the social determinants of health, the lens of the social determinants of health. I have an example structure. You don't have to hold too dearly to the specific page length or these specific structures, but just a good framework for you to use. Such as an introduction, your theoretical framework, your analysis, and then your conclusion and proposed interventions. You can see directions there under each. And then at least seven to 10 pages, include at least 7 academic sources, and then APA or ASA style citation is preferred, 12-point Times New Roman or something similar to that extent. Evaluation criteria you can see there as well. And then submit to me either using the submission link on the Moodle page. So if you go up, let's see, here you go, assignment paper number 1 due. You can see there's an actual submission link on the Moodle page as well. Or you can, if you're having problems with that, let me know. You can also just email me your paper, whatever works best for you all. All right, let's get into it today though, right? Let's get into gender health disparities. Before we do, I think it's important to discuss just a couple of key concepts right up front, which is, well, number one, being the social constructed nature of gender and health. So I'm just going to run through these things quite quickly because it's just a framework for how we're going to be thinking about this. So number one is that gender is socially constructed and that gender influences expectations and roles and behaviors, which in turn affect health outcomes. So what do we mean by socially constructed again? What do we mean by that? Is that the ideas, our conceptions around what is gender are shaped by culture, are shaped by our socialization, about the culture around us, about all the symbols, roles that are associated with gender. Not different than the biological reality or biological constant that is sex, male, female, intersex. Gender is something different, and the fluidity of gender. That is the social element, your expectations around your behavior as related to your gender, not talking about the biological components that is sex. Also, health risks and perceptions of illness and access to healthcare are often mediated by cultural understandings of things like masculinity and femininity. So be thinking about that's a framework that's going to be an important understanding. You want to understand that those things is reality. So the social constructed nature of gender, and that gender does have real impacts on our experience with health in this in society. Biological versus social determinants. So while some gender differences in health outcomes can be attributed to biological factors, so think of things like hormonal differences, pregnancy-related conditions. On the other hand, medical sociology emphasizes the social determinants of health, right? The things we've talked about, workplace inequality, caregiving burdens, other sort of societal expectations. All these sorts of inequities and inequalities also are key components of health. So again, we are considering the biological determinants, but we will largely focus on the social determinants of health as well as they relate to gender health disparities. And then power and privilege in healthcare. So gender disparities in healthcare stem from systemic biases and inequalities in healthcare systems, including gendered assumptions by providers and unequal distribution of resources. Historically, women's health concerns have been dismissed or largely minimized, and men's health issues have been underdiagnosed due to perceptions of invulnerability tied to masculinity. So there's a lot of really interesting gender dynamics at work here, both with traditionally man, traditionally woman, non-binary, and transgender gender dynamics in the healthcare system. We're going to be talking about all of these things today. And in your readings, they go even further in depth. So let's actually start getting into it now. Okay. So let's talk about gender health disparities. So just a couple objectives here. What I want you to get from the readings, okay, is exploring the intricate relationships between gender and health disparities, right? Focusing on the social, the behavioral, and the structural factors that influence health outcomes across different gender identities. And really what today is going to be grounded in is really foundational and contemporary, the academic readings we talked about that reveal that nuanced intersections of gender and health and medical sociology. So the objectives you can see on the screen there, but I want you to understand how gender roles and gender constructions, social constructions impact health outcomes. I want you to analyze disparities in healthcare access and utilization among different genders. I want you to explore how social networks and societal norms contribute to health inequalities, and I want you to critically assess theoretical frameworks explaining gender health disparities. So let's dive in. Introduction to gender and health. So just a couple of key terms that it's important to identify, important to understand. I've hit on a couple already, but let's outright define them. So what do we mean by sex? This refers to the biological differences between males and females, such as reproductive organs, chromosomes, and hormones. Gender refers to the social, cultural, and behavioral attributes and roles and expectations that are associated with being male or being female or whatever it might be. And gender is not biologically determined, but is a social construct shaped by culture and norms and experiences. So there's a difference there, right? There's the biological sex and the social experience of gender. What do we mean by health disparities? And I mean, this is central to the class, but just as a reminder, these are differences in health outcomes between different groups of people. So often influenced by social determinants like income and education and access to healthcare. So in the context of gender, health disparities can arise from both biological and social factors, which we will talk about. A couple of key explanations here as well around gender norms and health behaviors. Let's talk about gender, the influence here of gender norms and health behaviors. And let's talk about men's health behaviors, women's health behaviors, and non-binary and trans individuals' experiences as well. So starting with men's health behaviors, social norms often encourage men to engage in more risk-taking behaviors in society, such as smoking or drinking or dangerous activities, which can take and have negative health consequences, obviously. And these norms may also discourage men from seeking medical help or expressing vulnerability, which can prevent them from assessing needed health care. Women's health behaviors. So think about how women are often expected to be more nurturing and caregiving, which can then lead them to prioritizing others' health over their own in certain situations. And additionally, societal expectations may lead women to be more health conscious, but also more likely to internalize health issues and seek medical help. So which can have both positive and negative outcomes. So for instance, women may be more likely to receive preventative care and seek out that preventative care, but they might also face more medicalization of normal life events. Remember, we talked about what medicalization meant, the over-medicalization of potential life events like pregnancy and menopause and things like that. Now, let's talk to the experience of non-binary and transgender individuals. So individuals who identify as non-binary and transgender often face very unique health challenges due to societal discrimination and societal stigma. This can include things like limited access to gender-affirming healthcare, increased risk of mental health issues such as anxiety or depression, and higher rates of chronic health conditions. So moreover, cultural and societal norms may limit their access to appropriate healthcare resources and providers. So all these things lead to disparities in health outcomes. So those are really good. That's just a foundation of how can we think about how gender norms impact our actual behaviors around health, how we approach and understand health. So let's talk about also the distinction between biological sex and gender roles, number 2 there under the explanation. So biological sex, again, like I just mentioned already before, this refers to the physical characteristics that define males and females and intersexed individuals, so such as anatomy and chromosomes and hormone levels. Gender roles, on the other hand, these are societal, social expectations about how individuals should behave, how we're expected to behave and dress and act based upon our assigned sex. So, for example, society often expects men to be more masculine or strong or unemotional or risk-taking, while women are traditionally expected to be more nurturing and care-oriented. And obviously, these things are in flux and changing. We're in a period of people really constantly re-examining our gender roles. But it's important to understand the historical context. And historically, these have been those expectations. So the key point here is that gender roles are learned and really do vary across cultures, through things like assimilation through our institutions and through different time periods. While biological sex, it remains that constant, that biological constant. So gender roles evolve, biological sex does not. Number 3, health disparities by gender. So we're going to be thinking about physical health and mental health. So let's talk about physical health first. So men generally experience higher rates of certain diseases, such as heart disease, and have higher mortality rates in general overall. On the other hand, women tend to live longer but face higher rates of chronic illnesses, such as arthritis, and experience unique health issues related to things like pregnancy and childbirth. Mental health now. Let's talk about mental health. So gender norms also influence mental health disparities. So men may be less likely to seek help for mental health problems due to stigma around vulnerability and emotional expression, leading to underreporting of conditions like depression or anxiety. Women, on the other hand, tend to have higher rates of depression and anxiety, which can be linked to societal and social expectations and caregiving roles and experiences of gender-based violence. I also want to highlight the experience of non-binary and transgender individuals here as well. So these populations of non-binary or trans individuals experience significant health disparities, including higher rates of chronic diseases. So studies have suggested that transgender individuals may have higher rates of chronic conditions such as cardiovascular disease and diabetes and even HIV and AIDS. Unique mental health challenges as well. So transgender individuals face significantly higher rates of mental health issues such as depression and anxiety and suicidal tendencies, often due to that social stress and that chronic stress and of discrimination and stigma and a lack of social support. And they also, this community also faces unique barriers to healthcare because many transgender individuals experience discrimination and lack of access to culturally competent healthcare, leading to delays in care and misdiagnoses and poorer health outcomes, right? Non-culturally competent, especially when you think of that intersectionality component. If you're a white or non-white individual who's transgender, these sorts of things have become increasingly important to understand the nuances of someone's unique lived experience, and a group's unique lived experience often are not the case for this population. They do not have access to that. And then intersectionality is also critical here as well, right? So as with gender, the health disparities experienced by non-binary transgender individuals are further exacerbated by intersecting factors such as race and ethnicity, socioeconomic status, and sexual orientation. And so some other factors, or some of the factors that actually contribute to these health disparities that I think is important to point out, we talked about it, but number one, discrimination. So societal stigma and discrimination can limit access to healthcare and create barriers that we talked about to seeking care and contribute to mental health challenges. There's also a lack of data. So limited data collection on health outcomes for non-binary and transgender individuals has hindered our understanding of their specific and unique needs of these different populations. And the development of effective interventions has also been limited due to that. And then also just number 3, inadequate healthcare, already kind of touched on, but many healthcare providers lack the knowledge and the training to provide culturally competent and affirming care to non-binary and transgender individuals. And this oftentimes leads to misdiagnoses and mistreatment and poor health outcomes. So really important things to understand when we talk about gender, from the man, a woman's, and a non-binary transgender individual's experience, as this is really critical to understand, especially when we think right upstream versus downstream approaches. So some theoretical background and concepts. This largely comes from the Cochrane reading, that chapter 4 reading. And this section focused on how sociological theories explain gender health disparities. So two primary sociological frameworks that I want to discuss that really highlighted in the reading was the functionalist view and intersectionality. So structural functionalism is the theory in the functionalist view. So structural functionalism suggests that society has a unique division of labor where men and women are assigned different roles, which affects health outcomes. So for instance, men are often and had traditionally been expected to be providers and engage in riskier activities or riskier career pathways, which can lead to higher rates of accidents or chronic conditions like heart disease and arthritis. Meanwhile, women have traditionally been expected to nurture, which can create pressures related to caregiving roles and contribute to mental health issues. And in this framework of structural functionalism, again, thinking about how society has a very specific structure that allows it to function. And thinking that gender roles are a really big part of that. So this framework implies that gender roles are essential for maintaining social order, but it really fails to account for how gendered expectations can lead to specific health inequality. So for example, the emphasis of men being tough or self-reliant might prevent them from seeking medical care, leading to worse health outcomes. So that functionalist view breaks down slightly because we think, well, society is not then adequately functioning from a health-related standpoint, a longevity standpoint, if there are these health disparities persist due to the structured nature here. Intersectionality is the other one that is highlighted and is really, really important because intersectionality theory deepens the understanding of how we look at gender health disparities by examining how overlapping identities like gender, race, class, sexual orientation, et cetera, shape an individual's experiences and health outcomes. So for example, a Black woman may face health disparities not only because of her gender, but also due to the compounded effects of racism and socioeconomic disadvantage and chronic stress, the things we talked about in the previous class period, right? When we talked about racial health disparities. And so intersectionality challenges the notion that gender alone determines health outcomes, but really highlights how multiple social identities create complex overlapping barriers to health. And that's really important to understand. That's a really critical takeaway from sociology, from this course in medical sociology, that to understand individuals' unique health experiences in particular, we need to look at an intersectional approach of how different communities experience these things, especially from a population health standpoint. This becomes really, really critical. So let's get into then the other reading here, the Courtney reading from 2000, talking about masculinity and men's health. So this reading explores how masculinity is socially constructed and how these gender norms influence men's health behaviors. And so the author here is arguing that men who conform to traditional masculine ideals, such as stoicism, where you really don't show your vulnerability, or dominance or risk-taking, often experience negative health outcomes, and that these behaviors lead to higher rates of preventable diseases and reduced life expectancy. So a couple of key points from the reading here. Number one, hegemonic masculinity. So this concept of hegemonic masculinity refers to the dominant form of masculinity in a given culture. So often associated with traits like strength, self-reliance, emotional restraint, and a disregard for health vulnerabilities. And hegemonic masculinity pressures men to avoid behaviors deemed as quote unquote feminine. So like seeking help or showing emotion, again, thinking traditionally in society. And these things can really discourage health promoting actions such as regular medical checkups or mental health support. Number two, health implications. So men who adhere to these masculine norms that we just talked about are much less likely to engage in more preventative health behaviors, such as seeking medical advice or addressing certain health issues early. So waiting until it becomes a really significant issue to get treatment. And that creates worse health disparities too. So it leads to higher rates of chronic diseases like cardiovascular disease and more severe cancer and mental health problems like depression and anxiety, which all could be mitigated with that earlier intervention. Number three, the paradox. So despite having societal privilege in many areas, such as higher status or better pay, think about those economic disparities based upon gender, men still experience poorer health outcomes compared to women. So the paradox can be attributed to how masculinity norms prevents men from engaging in health promoting behaviors and seeking that necessary preventative care, even when they may have more access to those resources themselves. Again, showing the amazing power of our gender roles and how they relate to our health behavior. So a couple of other quick notes. So masculinity norms and health behaviors. Again, it's important to use this reading to understand why men may be less likely to engage in health promoting behaviors, or how avoiding regular doctor visits, maybe because it goes against the expectation to be more tough or to be less vulnerable, right? And these things, yeah, do these gender roles break down and change over time? Absolutely. But these are our traditionally held gender norms, especially in Western culture. And then again, think about some of the real life examples from the readings. Go back and understand the theory that Courtney is actually producing here. But let's dive into the Cameron reading now too. So health and healthcare disparities among older adults, because this is really important too when we think of gender and some intersectionality between age and gender. So this study examined gender disparities in health and healthcare use among older adults specifically. And it revealed that women tend to report worse health outcomes, such as chronic conditions and functional limitations, but tend to use healthcare services more frequently than men. So the authors here in this reading, it's so interesting that they're arguing that these disparities are influenced by a combination of social and economic and health insurance factors. So a couple of key insights here. So number one, that chronic conditions and functional limitations piece. So older women are more likely to report having chronic conditions like arthritis or osteoporosis and experience really functional limitations. So think of like difficulties with mobility or daily activities. And these health challenges increase their need for medical care. And number two, that there's higher mortality rates in men. So while older men report better health, they tend to have higher mortality rates, which suggests that they may be underreporting health issues or not seeking care as frequently, leading to more severe outcomes. Again, connecting to some of those health-related behaviors due to those societal pressures and norms that we just talked about in the previous slide with the Cochrane reading, with the Cameron reading. So the Courtney reading. So really important to understand, but again, how that impacts into these older adults, as you see in this reading. So there's a lot of implications for policy and healthcare accessibility on this front too, right? So these findings suggest that healthcare access and utilization are influenced by these gendered factors, as we very well know from the other readings and from our experiences. So older women may face barriers in accessing care. So whether that be financial or social barriers, even though they utilize healthcare services more. So an interesting dichotomy there, that there may be more barriers, but they still are accessing it more. And so men, on the other hand, may be less likely to seek care or report health issues, potentially due to social norms around masculinity that discourage seeking help. And so there's gendered expectations in older age as well that I think is important to highlight. So really think about how societal expectations of women as caregivers and men as self-reliant individuals might shape health behaviors and healthcare usage in older adulthood. How do those things evolve as we get older, as empty nesters, right? Even though, as you looked at as the caregiver model, what is that? What does that look like in retirement and in your 70s, your 60s, your 80s, your 90s? Think about that. And also think about why do women utilize healthcare more frequently than men despite poor reported health outcomes? I really encourage you to think about the social and the economic and the cultural factors that influence healthcare seeking behaviors in older adults. And that could be a really good foundation for maybe a discussion prompt this week. The role of social networks and behavior. This is from the Gamper reading, the 2022 reading. And here the reading is exploring how social networks contribute to gender health inequality. So think about social networks again as your resources, the people you know and the connections you have, and the connections, like think of your general networking, right? You know this person who knows this person who knows this person who knows this person. Those are really important in understanding our social situation, our social capital, our social power, our social mobility. Those resources in your social network is really critical. So The authors here are highlighting that men and women experience and utilize their social networks in very distinct ways. So, and this significantly affects their health, behaviors, and outcomes. And so social support, which often comes from our networks, can be both a protective and a risk factor depending on the quality and type of social interaction. So let's talk, just let me define a key term here, that being network capital. So network capital is a term that refers to the resources individuals can access through your social connections, through your social network. So think of things like social support or information and education and even advice and professional connections. And it's really important to understand that network capital can vary by gender, with women often having stronger emotional support networks, while men may have more instrumental support. So this is oftentimes a trend that we see, and now we're looking at how that impacts health outcomes. So a couple of big takeaways here. Number one, the differences in network structure, that men and women tend to have different types of social networks. Women often have more emotionally supportive networks and tend to rely more on family and friends for health-related advice. Now, men, on the other hand, may have more instrumental support, things like work-related help, and are often less likely to seek emotional support. Really important to understand those differences in terms of through the lens of our social networks and health behaviors and outcomes. Now, number two, social networks mediate health behaviors. So social networks influence health behaviors by providing information, by providing emotional support and practical assistance. So for example, a supportive social network may encourage healthy behaviors, while negative social interactions, things like more toxic relationships, could contribute to stress and poor health outcomes. So again, these networks, these social networks, are a mediator. I mean, they help to explain and impact our specific health-related outcomes, and they can be both positive and negative. Again, positive being things like encouraging health behavior, like if your social network, if your peer group, we're going to go for runs or walks every day, or hey, I know it's cold out, but let's go to the mall and let's mall walk for a couple of miles a day in the winter, or let's eat healthier, or you're going to less fast food and you're eating in more, you're buying better produce. It can also be negative. So those negative social interactions, like toxic relationships, like a more negative peer support group, like abusive relationships, and that negativity, that also contributes to stress and poor health outcomes. So again, positive and negative. So the role of social networks in our health behavior, it really does differ by our gender in terms of the connections and the resources and the types of social networks. And it's important to understand that, and that's what this reading is really highlighting. So we're going to look at as well some gender-specific patterns in health outcomes. This is also really, really important to take a look at. So let's look at men, let's look at women, let's look at men, and then transgender and non-binary individuals. So specifically, let's start with women. Let's start with gender-specific patterns and health outcome for women. So women tend to have higher morbidity and higher and lower morbidity here. So women often experience higher rates of chronic illness. So things like arthritis and autoimmune diseases, but also tend to live longer than men. So there's an interesting dichotomy there that women tend to experience those higher rates of chronic illnesses. Again, those things that just are longer lasting, but also tend to live longer than men. And those two things may be interconnected. There's also a caregiving burden that women historically have had, especially in Western culture. So women often assume caregiving roles in society, which increase stress and limit their time for self-care and accessing healthcare, which are incredibly important. And then on the mental health side, women on average experience higher rates of depression and anxiety. At least that's the higher rates of depression and anxiety are reported among women. And that's partly due to social pressures and gender expectations. So those are really important things to understand, that these are really impactful gender-specific patterns that women have in terms of their health outcomes. Now look at men on the other hand. So men tend to engage in more risk-taking behaviors, things like substance abuse and dangerous occupations, and are less likely to seek preventative care. And all of these things lead to a lower life expectancy. So men do have lower life expectancy statistically than women do. There's also different masculinity norms. So cultural expectations, like we've talked about, things like toughness and stoicism, these things discourage men from acknowledging or addressing health issues. And these things then, in turn, contribute to poorer health-related outcomes. And then again, on the mental health side, similarly, men are less likely to seek treatment and to seek help for mental health issues, and therefore also tend to have higher rates of suicide and completed suicide. Those are things that are really, really important to understand about these gender differences. And then 3, transgender and non-binary individuals. So number 1, healthcare discrimination. So trans and non-binary individuals oftentimes face systemic discrimination and a lack of provider knowledge. You go to the doctor, again, that lack of cultural competency, as well as stigma when seeking care. There's also barriers to access related to this. So things like financial barriers, a lack of insurance coverage for gender affirming care, and provider bias. All these things exacerbate the health inequities and disparities of specifically these non-binary and transgender individuals. And then mental health, again, because it's really important to highlight that discrimination and social marginalization. These things contribute to higher rates of mental health issues and suicide attempts in these populations of transgender and non-binary individuals. And so it's important, again, remember we talked about policy implications. I think there's a final slide here that will hit on that. Why these downstream and more foundational, grounded approaches are important, because we have to understand what are the outcomes that these by gender that folks are experiencing. Like, think of the transgender non-binary experience, or the experience of a woman in society. How do we look at these differences and think backwards? Think, okay, this is the outcome that's happening. Where in the process do we need to change? And the answer is foundationally in our healthcare system. So we'll get into that final slide though. Here are some social and structural factors driving disparities, also important to point out. So there's 4 here that I've listed. Number 1, cultural norms and gender roles. So kind of already talked about this, but expectations tied to gender roles shape our behaviors around things like our diet and exercise and risk-taking and our willingness to seek cares. For example, women are often expected to prioritize caregiving even over their own health, while men may avoid seeking care due to the perceptions of things like weakness and vulnerability. Number 2, economic inequalities. Women on average earn less than men for the same exact education level, for the same career pathways. And this limits their ability to afford healthcare, right? Because healthcare is increasingly expensive and tied into our economic standing. And so occupational segregation means that women are more likely to work in lower paying jobs, oftentimes jobs even without those health benefits. Number 3, provider biases. So studies show that healthcare providers are more likely to minimize a woman's pain or attribute symptoms to emotional or psychological causes in women compared to men. So more likely to minimize those symptoms or pain in women than men. Transgender individuals often encounter providers who lack training or exhibit bias, leading to, again, those things that we talked about, inadequate care and misdiagnoses. So when people talk about, well, why is cultural competence important in healthcare? I mean, if they're just looking at your healthcare, it's a black and white, right? You're looking at, are they sick? Are you not? Do you have a condition? Do you not have a condition? It's not that simple, because being culturally competent means that we can understand and connect with our patients better, understand these individuals better. More cultural competence leans to less things like disregarding symptoms or ignoring symptoms or minimizing pain or not attributing it to an actual potential root cause of a greater condition or a disorder. And that means that when we have greater cultural competence, we can then diagnose and provide greater preventative and adequate care at that time, which of course then leads to better health outcomes. So cultural competence is incredibly important. Finally, there, number 4, under the social and structural factors driving disparities, access to resources. So structural barriers such as the lack of childcare or inflexible work schedules or transportation issues, these things disproportionately affect a women's ability to access healthcare. Men in rural areas or traditionally masculine industries, things like construction and manufacturing, may face similar barriers as well. So again, access to resources also incredibly important. Just like the last slide quickly before we have one more, but just really a last slide and then a couple of reminders. Interventions and solutions. So let's talk about the types of healthcare interventions that could be had. So number 1, gender-sensitive healthcare. So training healthcare providers to recognize and address gender-specific needs and biases can improve outcomes. So policies promoting equitable access to gender-specific care, like maternal health services or prostate cancer screenings, for example. These things are essential. So those gender-specific healthcare, identifying that, making sure that we're including folks from non-binary and transgender populations in this gender-specific care is really important. Number two, community-level interventions. So programs that address gender norms, such as discouraging men to seek preventative care or reducing caregiving burdens on women, programs that address those gender norms can mitigate those disparities well. And when you communicate those out and make sure that those are understood. And supporting organizations that provide care for marginalized populations, such as transgender and non-binary individuals, that's also critical for all the reasons we've mentioned before. And then number three, policy and structural changes. Advocacy for pay equity, parental leave, and expanded healthcare coverage can address economic and structural barriers to care as well. And then funding for research on gender-specific health issues, particularly for those underrepresented groups, again, like transgender and non-binary individuals. This type of research can help to close the knowledge gaps that we really need to close in order to have better healthcare intervention. Remember, we talked about the limited data that we currently have on these populations. We need to fund research in these areas so then we can understand more on gender health disparities. We can have better interventions as well. So these are potential interventions and solutions, and you could dive into specific ones, right? And maybe you do that for your reflection prompt or as a part of one of your papers or your presentation. You could look at this and take some of these broader frameworks and let's dive into really specific interventions that we can look up. And there have been proposed, but you can do research on that. And there's some really interesting ideas out there. Finally, just wanting to wrap up here on the intersectionality component. So just want to highlight first medical sociology perspective again on gender health disparities. So again, when we talk about gender health disparities, we're referring to the differences in health outcomes and access to healthcare between men, between women, and people of other gender identities like transgender and non-binary individuals. And from this medical sociology perspective that we've discussed today, these disparities arise from a combination of biological and social and cultural and even structural factors. So medical sociologists explore how gender norms and gender roles and systemic inequalities impact health behaviors and health care access and outcomes. And so the medical sociology perspective on gender health disparities really does reveal that these inequities are deeply rooted in social structures and cultural norms and systemic biases, and that addressing these disparities requires a multifaceted approach, including systemic policy changes and provider education and earlier education and community level interventions with a focus on equity and inclusion, especially for those marginalized populations. So again, and this is really a lot of it comes from the Barkan reading, but I also want to just finally highlight this intersectionality approach and how gender intersects with these other social determinants like race and socioeconomic status. And what this does is it compounds health disparities. So this section, especially in the Barkan reading, just a couple of pages, emphasizes that importance of considering multiple intersecting factors such as race and class and gender. We've been talking about these things now, right? And so now we can understand how these things intersect. And so when you study these health outcomes, make sure you're including those intersectional approaches. And so by recognizing these intersections, this intersectionality, we can better understand how different forms of inequality overlap and intensify health disadvantages for specific groups. So again, think about those things: intersection of race, class, sexual orientation, and age. And if we're like, as an example, so a low-income woman of color may face compounded barriers to health care access compared to a middle-class income woman or white woman instead. So just as an example, again, think about how the experience of intersectionality and how intersectional approach in studying gender health disparities is a much more comprehensive view and crucial for understanding the really complex and multidimensional nature of health inequalities. And that goes for everything, right? That goes for all of the medical sociology perspective. If we're trying to explain racial health disparities, there's likely a gender component included as well, age and socioeconomic status. And we've talked about all those things. But now, especially as we're more midway through the course and getting into more applicational side of things, I want you to make sure that you're including those intersectional approaches because it's really critical. So that's why I included this as the last slide, because as we think about these and have a good understanding about age and race and gender and socioeconomic status and environment and exposure, all those sorts of things, that we take it all in. when we're looking at health related outcomes, and as we look at how we're going to address these as practitioners in society. And I can't wait to hear more on all of that in discussion prompts and in papers and your final presentation. So as always, please let me know of any questions that you do have. Happy to meet one-on-one as we have been, as always. So thanks again for tuning in, everybody, and we will see you in the next class period.